how to handle non-culprit lesions in the patient with ST elevation myocardial infarction has been a hot topic, a heated topic even, in the last few years. We are here to address this issue, and actually one more too, based on a focused update, 2015 ACC AHA SCAI focused update on PCI for patients with STEMI. And for this, I want to talk to Dr. Eric Bates, who is a professor of internal medicine at the University of Michigan Medical Center in Ann Arbor. But for our purposes today, while a member of this particular committee, he is also, more important, you probably know him as the vice chair of the PCI Writing Committee. We have had conflicting results about the benefits of non-culprit PCI for some time. This is an important issue, isn't it?
Yes, it is. So for years, that was a class 3 recommendation. Based, I think, on early experience many of us had when we had inadequate antiplatelet and anticoagulant therapy and we didn't have stents, and doing more often got us in trouble with complications in the second artery than the first artery. So for 25 years at least, the practice has been to only work on the culprit lesion and then undergo the evaluation based on ischemia-guided therapy as to whether or not to revascularize other lesions if the patient had multivessel disease. And about 50% of these patients do. But there have been some observational studies over the last 10 or 12 years looking at this, supporting the guidelines, but most recently we've had some randomized clinical trials that have yielded the opposite results and reinitiated the discussion about the possibility that with better antithrombotic therapy and stents and other advances, that it might be more efficient and even save resources to do multivessel revascularization at one setting instead of two settings.
Before we talk about the change, you know, there is this stenotic optic reflex, as it's called, as an interventionist sees a stenosis and he wants to fix it. Was there any pushback when the guidelines kind of, you know, with the guidelines hanging on to the, it's a class 3, it could do harm? Was there any criticism of that, or was there any, come on, get this thing changed?
Well, the Europeans have, at least the year before us, already raised it to a 2B recommendation. And some people are enthusiastic about pursuing this new treatment strategy. But it's important to recognize that the European guidelines actually give a rather cautious green light to this. It really is only supposed to be in selected patients. It's not supposed to be complex lesions. It's not supposed to be patients with 50% stenoses, in my opinion, or total occlusions. The patients have to have a uncomplicated infarct artery PCI and not have any risk for volume overload or contrast nephropathy, which could harm them and actually is associated with death in hospital. So the strategy, I think, has been demonstrated in the current era to be safe. We're still arguing about efficacy.
Right.
We still haven't proven whether it actually does decrease the risk of death or MI.
So what is the new guideline update on the 21st of October, I believe is the time it's going to be, the embargo is going off. What's it say now in terms of what to do for these patients?
So the guideline sunsets the class 3 recommendation saying you should not do it, and it matches the European guideline recommendation that it's a 2B recommendation in selected patients. So if you want to do it, I think the artery still has to be an artery that would pass standards for elective PCI. I think it probably should be a really tight stenosis, not an intermediate stenosis, in a really stable patient. And basically the reason to do it, I think, is to be more efficient. Say if somebody comes in on a Friday and you're going to have a two-day hospital stay instead of 4 or 5 hospital stay, that might push you toward doing it. But I think we need to be really careful not to embrace this new strategy too aggressively and cause patient harm, because most people in the U.S. still pursue the deferred strategy, which has been standard of care for a long time. Just wait a couple days and do the other artery when you know the patient better, maybe have more information on the appropriateness of doing PCI.
So in terms of the definition of multivessel revascularization, what you're talking about is you can, now if you see it, you're in there anyway, you can work on it.
The recommendation is in selected cases,
right.
In lesions that meet appropriate indications for PCI, you can have a go at it as long as you think that's the best treatment strategy for that patient.
I think it was Dr. Sharma who was doing an Excel interview and talking about a 130 center study that should hopefully give us a better answer on this whole question as to efficacy.
Right, so this is a really hot area of investigation, as you mentioned. There, in fact, have been 17 meta-analyses on this subject.
Jeez.
There are now 10 randomized trials looking at different combinations of timing. And the study you referred to, I think, is the COMPLETE trial, which is going to be a 3,900 patient study coordinated out of McMaster. It's going to compare culprit-only PCI versus staged PCI, but it will not answer the question of whether multi-vessel revascularization can be done in one setting or two setting. It will be the data source to make a recommendation on staged PCI, which we do not have at the present time.
Now, there is a second topic that is addressed in the updated guidelines. What's that?
Yes, another very hot area in this field, and the reason why the update is being put out before a new guideline is completely rewritten is thrombus aspiration.
Right.
So as you remember, a few years ago, the TAPAS study, a single center study of over 1,000 patients, showed EKG benefit and even some mortality benefit with thrombus aspiration, which is a fairly simple procedure to perform. But subsequently, including trials reported today at the TCT meeting, there have been 2 trials showing no difference in infarct size. And then we have 2 very large multi-center trials, one from Sweden and one from the McMaster folks, again, showing absolutely no benefit on any endpoint with thrombus aspiration. So in the prior guideline, thrombus aspiration was given a 2A indication, meaning you should think about doing it. And in the present guideline, it's now a class 3 indication for routine thrombus aspiration. We really don't have enough information to comment on the benefit of selective thrombus aspiration, which is still clinically done. But the class 3 recommendation is partly because of no efficacy. And then in this total trial from Canada, they actually had a signal of harm with an increase in stroke. So there's the possibility that during the thrombus aspiration, some thrombus gets loose between the os of the artery and the tip of the guide catheter. So no benefit is one problem, harm is another problem. So it's no longer recommended in our guidelines or in the European guidelines as a routine strategy.
We've talked to Dr. Jolly a couple of times, and the last time it was really depressing, as there was the great buildup, and this was going to be the trial that answered the question, and I don't think.
It makes great sense, but the problem, I think, is number one, we're getting there too late. So I'm not surprised there's no evidence for myocardial salvage, but I think the bigger problem is the catheters we use don't have a big enough hole to suck the clot out, and we simply aren't getting adequate thrombus aspiration to test the hypothesis, which intuitively makes a lot of sense and is quite attractive.
Yeah. Well, I know it's tough to get agreement on things, so congratulations for on 2 topics and 2 controversial ones. Please check online because the guidelines are now out. If you're looking at this, we didn't break any embargo. And please check it out online at acc.org and go to Jack. For CardioSource World News, I'm Executive Editor Rick McGuire. Yes, as an editor for Jack, they would kill me if I broke the embargo.
I would